Good morning, Dr. Sarat. Thank you very much for joining us with the HaploX Precision Talk today. It is a great pleasure to have you out with us today. Before we start, I would like to briefly introduce with Dr. Sarat today. Dr. Sarat is a medical oncologist in Thailand and is listed by the Thai Society of Clinical Oncology. With his affiliated hospital shown as Klang Hospital, his clinical work placing in the front line of cancer, where decisions around genetic testings, target therapies, liquid biopsies, and disease monitoring are increasingly becoming a part of cancer treatment. Today, we are especially honored to hear Dr. Sarat's real-world clinical perspective on how liquid biopsies and MRD testings are being understood and applied by oncologists and in patients in Thailand. Let's start with the broader picture.
Okay.
So how has genetic testings changed clinical decision-making, Dr. Sarat?
Okay. I think the biggest change is that genetic testing has moved from being just a diagnosis to becoming part of real-time treatment decision-making. With NGS and liquid biopsy, we can now identify actionable mutations, select targeted therapies more precisely, and also monitoring tumor evolution over time. In practice, this means faster treatment decisions, less invasive testing, better detection of resistance, and more personalized treatment strategies. Precision oncology today is much more dynamic than before.
So, Dr. Sarat, in your daily practice, how acceptable is dynamic monitoring and what are the barriers?
Patient acceptance is generally very high because blood testing is much easier than repeated tissue biopsy. The main challenge are interpreting complex molecular results, limited sensitivity in some tumors, lack of standardization, and cost or reimbursement issue. Another interesting emerging concept is more proactive strategy, where treatment may be adjusted based on molecular progression before radiographic progression. For example, in studies such as SERENA-6, adapting treatment according to ESR1 mutation detection has shown promising results. It suggests that in the future, we may intervene earlier based on biological progression rather than waiting for imaging progression. This is not part of current guidelines yet, but it could become increasingly relevant if ongoing studies continue to show meaningful clinical benefits.
What is the greatest value of MRD and what are the challenges?
Okay, the biggest value of MRD is earlier detection of molecular recurrence before imaging show relapse. It may help us personalize adjuvant treatment deciding who truly needs escalation or who may avoid unnecessary therapy. The main challenges are sensitivity in very low disease burden, variability in circulating tumor DNA shading between different tumor types, assay standardization, and the fact that current data are still stronger for prognostic value than predictive value. So while MRD positivity clearly identifies patients with higher recurrence risk, we still need more solid evidence showing that MRD-guided intervention consistently improves survival outcomes. But overall, I think MRD will become increasingly important in the next few years.
How do you use liquid biopsy for resistance monitoring?
This is already one of the most practical uses of liquid biopsy today. Cancer evolves under treatment pressure, and liquid biopsy helps us identify emerging resistance mechanisms such as EGFR, T790M mutation, MET amplification, ESR1 mutation, or RAS mutations. I usually use it when disease progression, tissue is limited, or rapid molecular information is needed. Importantly, we always interpret the result together with imaging and clinical context.
So how do you view multi-cancer early detection in blood tests?
Okay, I think multi-cancer early detection blood test or MCED is very promising, especially for earlier cancer detection through a simple blood test. But we still need to be careful because important concerns remain false positives, overdiagnostic, healthcare costs, or whether it truly improves survival outcomes. At the moment, I see it more as a complement to standard screening rather than a replacement.
So Dr. Sarat, we know that AI is very prominent nowadays, and especially in clinical oncology settings. So may I ask, how will AI and multiomics change the clinical perspective?
I think oncology is moving towards a much more integrated and data-driven approach. AI will help us combine genomics, proteomics, imaging, and clinical data to better predict treatment response and resistance. I see AI mainly as a clinical support tool that helps clinicians make more precise decisions, not something that repairs clinical judgment.
So also, what are the opportunities and challenges does the Southeast Asia market face in precision oncology?
Southeast Asia has huge potential because we have large patient populations and unique molecular profiles, but there are still major challenges: unequal access to testing, reimbursement limitations, and limited molecular infrastructure in some areas. I think the future will depend on stronger regional collaborations and making precision oncology more accessible beyond large academic centers.
Thank you very much, Dr. Sarat.
Yes, thank you.